Hi, in Biochemistry Bits, today we are going into case-based biochemistry discussions, episode 8. Come, let's move to the case scenario. Here comes a clinical presentation. A 17-year-old male, incidental mild jaundice, intermittent yellow eyes is there, okay, resolving spontaneously, no fever, weight loss or itching. On physical examination, the boy had mild icterus, dark urine, but normal colored stools, no hepatosplenomegaly. An important finding was their family history. Sibling with a similar self-limiting jaundice, that is a clear hereditary component. So we know it is a hereditary hyperbilirubinemia. Now we want to identify whether it is conjugated or unconjugated. So for conjugated or unconjugated, you need to do the Vandenberg test, that is estimation of serum bilirubin. So serum bilirubin total was around 3.6 milligrams. Out of that, 2.3 was conjugated. So now we may relax a bit because conjugated is water soluble. So we saw an episode of Crigler-Najjar syndrome where there was a family history in a very young child, 1 to 3 days born child. So there we were worried about the type of bilirubin, and we have a separate video on Crigler-Najjar syndrome. Here it is conjugated bilirubin, so it is also a little mild jaundice, 2.3. And in addition, we performed all the liver function tests and abdominal ultrasound. Everything was completely normal. So this makes us feel a little better with the diagnosis. So all these findings together points towards the diagnosis of a condition called Dubin Johnson Syndrome. What is the biochemical basis behind Dubin Johnson Syndrome? For that, you need to understand the molecular mechanism involved. There is a particular ABCC2 gene mutation. It is a ATP binding cassette transporter. In that, there is a subfamily C and 2. C2 gene, that particular gene gets mutated. What does that gene do? It is going to code for a protein called MRP2. What does this protein do? It is the protein which acts as a transporter and pumps all the conjugated bilirubin from the liver into the bile duct. So if this protein is going to be defective as a result of ABCC2 gene mutation, the conjugated bilirubin cannot enter into the bile duct. So as a result, conjugated bilirubin piles up inside the liver and it also increases in the blood. But the most important thing here is LFTs were all normal. Though this conjugated bilirubin is all accumulating inside the liver function test is perfectly normal. In addition, there will be only one finding. Even though the liver architecture was normal in the ultrasonogram, you will have a black liver jaundice. The black liver is because of dark pigment accumulation, which is supposed to be expected because of the metabolites which were transported through this MRP2 protein other than this conjugated bilirubin. Most frequently which are implicated is the metanephrine, epinephrine metabolites. That is what is given in literature. So that is the abnormal pigment which is going to deposit in the liver, and that is why this is called the black liver jaundice. So this is the only place where you will read this finding. Black liver jaundice is nothing but Dubin Johnson syndrome. So let me give you an extra additional fact in this, which is a diagnostic fingerprint in case of Dubin Johnson syndrome. So here you have urinary coproporphyrin reversal. Okay, urinary coproporphyrin, you would have seen this in steps of heme synthesis. In a normal patient, most of the urinary coproporphyrin isomer is isomer 3. 75% is isomer 3. Only 25% will be isomer 1. But in case of Dubin Johnson patient, more than 80% of the isomer is isomer 1 and less than 20% is isomer 3. So there is a ratio reversal of this coproporphyrin isomer. What is the reason? If you see, coproporphyrin 1 has an increased affinity for this MRP2 protein. So that is why it is not able to transport and it gets diverted and gets excreted in the urine. So there are a lot of proteins or lot of compounds or metabolites which are going to be transported by this MRP2. So those are those substances cause the various manifestation of this particular Dubin Johnson syndrome. So to summarize, Dubin Johnson syndrome is caused by ABCC2 gene mutation which codes for MRP2 protein. It is a case of hereditary conjugated hyperbilirubinemia, and in short it is referred to as black liver jaundice.